What is happening here? Okay, so the heart is contracting, the ventricle is filling, it is contracting, but where is the blood going? It's going through the mitral valve, right? Back to the lungs, right? And so what's going to happen to that ventricle when that lung keeps sending the blood back to the ventricle? What eventually is going to happen? It's going to overfill. The ventricle is going to dilate to accompany that. And initially it's going to be good. That overfilling, what's going to happen when that overfilling happens? What's going to happen to the actin and myosin? They're going to stretch, and Starling's law is going to kick in, right? And that's going to increase the contractility, right? And so that's going to push more blood forward, right? Except where's the blood going to go? Backwards. So we still got some blood going forward, but we've got some blood going backwards, right? So that's the first thing. We've got too much blood going backwards. Now, Chesty might start coughing because we have left atrial enlargement. When we do that, we put compression on the main stem bronchus. Does not necessarily have pulmonary edema yet, but he might start coughing. Okay, so all this is going on. So in the meantime, what's happening to the cardiac output? It's going down, right? And it's going down because a lot of the blood's going backwards, right? Okay, so what's the body going to do when it sees that decreased cardiac output? So it's going to attempt to increase it. Now, first of all, what's the signal telling the body that I've got decreased cardiac output? What is actually happening at the tissue level? Hypoxia. We've got low tissue perfusion because we've got low cardiac output, and therefore there's low oxygen. Is that making sense? Okay. So the body's starting to put into play mechanisms to increase that cardiac output. And you told me, how can the body increase cardiac output? What tools does it have to do that?
Increase heart rate.
Great. Increased heart rate, right? Let's just pump it faster, and that will increase cardiac output. So what mechanism does the body have to increase heart rate?
Beta 1.
Say it again?
Sympathetic.
Sympathetic. Give me a mediator.
Beta 1.
Beta 1, that's the receptors, right? I don't know who said it, but that's the receptors. Now I need something to tell those beta receptors what to do. Epinephrine. Okay, where's that come from? Yeah, the adrenal gland. There's probably some being made in the heart as well. Okay, so the body's going to start putting out epinephrine, and that's going to increase tachycardia, right? Increase the heart rate, okay? And yeah, Chesty's heart rate is 120, maybe 150. Is that good? What's the problem with that fast heart rate?
The heart might not be filling.
The heart can't fill properly because it's beating so fast it doesn't have time to fill. What else is the problem with that rapid heart rate? What happens during diastole that is critical to the healthy heart? It gets its own blood flow. It is only when the heart is relaxed that it can get its own blood flow, its own oxygen. So if I've got a rapidly beating heart, that might be good for cardiac output in my peripheral tissues, but it's putting the heart in harm's way. Is that making sense? Okay, so we've got this epinephrine floating around. Okay, what else can the body do to increase cardiac output? It can increase contractility, right? Sure. So how's it going to do that? Say, yeah, positive, what'd you say?
Chromotropic, right?
So positive inotropic effect? Okay, so good, but tell me what mechanism. How can it do that? How can it increase contractility?
Calcium.
Well, we could increase calcium flow into the myocardium to get the actin and myosin, so that's one way if we could get more calcium in there. Okay, but what do you know? You know how the body can increase contractility. How does it do it? And it does it this way. This is how it increases calcium flux. How does it do it? So we're trying to increase contractility right now. Did I hear somebody say increase preload?
Yes.
Yeah, you can do that. How does increased preload increase contractility? Yeah, Starling's law, right? So that's one thing we can do. We can increase preload, right? Not only does it increase contractility, but it actually increases stroke volume, right? Okay, so how do we increase preload? What is preload? Does anybody know what preload is? How much blood is filling the ventricle, right? Right and left. We're interested in left because that's the workhorse, but it's going to increase right. How do we increase preload? How do we increase that volume in there? Say it again. Did I hear dilation of the ventricle?
No, blood vessels.
Oh, the blood vessels. Dilating the blood vessels. How will dilating the blood vessels increase preload? If we talking about arterial side, if we increase the arterial vessels, then the blood's going to go to the tissues, right? And then it's got to go through the veins before it comes back to the heart. I don't know it might increase delivery to the tissues, but I don't think it's going to increase delivery to the heart, is it? Because ultimately it's still going to be collected. So how else can we increase preload? So what did I hear? Brain, okay, so tell me how that brain natriuretic peptide, and actually I think it does just the opposite. Brain natriuretic peptide will probably decrease preload, so hold on to that for just a second. Okay, what does renin-angiotensin do? It increases aldosterone. Now we're getting somewhere. Now you're giving me a signal. And what does that aldosterone do? It causes sodium and therefore water retention. Where does it do that? In the kidney. Okay, so if I retain water, sodium and water, I'm increasing blood volume, right? And that will increase preload, right? Is that making sense? Okay, what happens if I do too much of that? Because where's that preload going? Left ventricle, right? Right? And so where is that preload going now when the heart contracts? It's going forward, but it's still going backwards, right? So now if I've increased preload too much, what have I increased the risk of? Pulmonary edema, right? Okay. So I guess, let's come back to this idea of contractility. Now, you told me that I could increase contractility, which would also help increasing, I've got increased stroke volume, right? Can I increase the heart's ability to contract and get that out of there? Yes or no? Okay, so how do I do that? We skipped over this, but let's come back to it. How does think of flight or fight, right? When you get ready to run, your heart rate goes up. When you're getting ready to run, you need greater tissue perfusion, right? So what's the body do to get that tissue perfusion there? Immediate. You've already told me one thing, it increases the heart rate, right? Okay, what else does it do? It increases contractility, and how does it do it? Sympathetic system, that's right. And what's the signal there? Epinephrine. And where's it come from? The adrenal gland, that's right. So I don't want you to forget, and as the body increases heart rate, it's also increasing contractility, and it's doing that in one fell swoop with epinephrine. And that potentially is going to increase cardiac output. Now it turns out that if my heart is beating harder, contracting harder against this large volume of blood in the ventricles, what do you think is going to happen to those myocardial fibers? They're going to hurt, they're going to tear, they're going to stretch, and that is potentially going to damage my heart. So this increased contractility is not necessarily an all positive thing either. Okay, so you've got an increased preload, right? And that will hopefully increase cardiac output. You've told me increase stroke volume, and you've done that by increasing contractility and increasing the preload. And then you've told me increasing the heart rate, right? So we've got aldosterone and we've got epinephrine. All right, so what else can the body do to maintain tissue perfusion? There's one more tool it has at its disposal to make sure that critical organs get blood. What can it do? It can reroute. And how does it reroute? It vasoconstricts. That's exactly right. It will vasoconstrict those arterioles that it perceives doesn't need the blood as much as the other tissues do, the brain. So, what signals does it have to vasoconstrict?
Alpha 1.
Okay, so alpha 1 is one way to do it. And so what's going to cause alpha 1 constriction?
Norepinephrine.
What else? You'd say norepinephrine? Okay, what else? Because we don't shoot a lot of norepinephrine now. What else do we shoot out? Epinephrine. Is epinephrine not a vasoconstrictor? It's not as good as norepinephrine, but it is a vasoconstrictor. And it's the same epinephrine that has increased cardiac output and by increasing contractility and increasing heart rate. So it's also going to cause increased peripheral arterial vasoconstriction. What's the word that we use for that? When we increase resistance vessels constriction, what's the term? It's afterload, that's right. Preload is loading the blood into the ventricle. Afterload is what happens on the other side of that aortic valve. The heart against which, the load against which the heart has to work. Afterload. Okay, so that's good. Is there anything else that can cause vasoconstriction? You mentioned something about this renin-angiotensin-aldosterone system. What's that all about? What's angiotensin do? It's a potent vasoconstrictor. It will tell aldosterone to go up, but it itself is a potent vasoconstrictor. Is that making sense? So now I've got two mediators on board that will vasoconstrict. Okay, now is that vasoconstriction a good thing or a bad thing? So let's work through this just a little bit. Okay, so what's happening to the blood when the ventricles pump? It goes backwards and it goes forward, right? We want it to go out the aortic valve, but a lot of it is going backwards, right? Is there anything that we've done here that's going to increase the amount that goes backwards instead of the amount that goes forward? The vasoconstriction. We've increased afterload. When we increase afterload, while the intent is to make sure that blood goes to the brain, what we're doing is we're making it much harder now for the heart to pump out the aortic valves, and now that means much more of it is going back through the AV valves into the lungs. Now what can we do to resolve that? So let's go through the pathophysiology here and think about that. So let's just summarize what we've done so far. So here's our failing myocardium, right? So what's going to happen is we're going to have decreased cardiac output. Now, the biggest signal occurs at the kidneys. The kidneys are going to perceive that it's not getting the blood supply that it needs, and therefore it's going to conclude that the rest of the body is not getting the blood supply it needs. So it's going to put into play ways to increase cardiac output so that we can, and here's the ultimate goal, increase tissue perfusion and oxygenation. That's what this is all about. So what the kidney's going to do is going to increase renin release. In the body, that renin is going to stimulate angiotensin release from the liver, and then its conversion to angiotensin 2, and that is our active mediator, angiotensin 2. Now, for that to happen, we happen to have in the vasculature angiotensin converting enzyme. Now, that's in the vasculature, but it's also in the individual organs as well. But what that does is it converts angiotensin 1 to angiotensin 2. And now suddenly, we got a lot going on. The first thing we got going on is vasoconstriction, increasing afterload. That will help reroute the blood to where it needs to go. So that's what this is, increasing afterload. Now, it turns out, and you didn't mention this, but it is part of our role players here, it will also cause the release of vasopressin and endothelin. Do you guys remember these mediators at all? They're potent vasoconstrictors as well. So that's going to increase afterload. And then if that's not enough, we have that epinephrine that's been released from the adrenal gland. That's going to increase vasoconstriction. So in this animal with a failing heart, we have a massive increase in afterload. We have really put a lot of strain on this heart because this heart is now going to have to pump against all that increased afterload in order to try and get the tissues perfused. So that's going to make those fibers stretch even more, a little bit more tearing, and it's potentially going to increase the risk of pulmonary edema. Now, on top of that, we have the increased heart rate that catecholamine release has done. And we have the increased contractility. So epinephrine doesn't just increase afterload, but it has these other positive, initially positive effects with the intent of increasing cardiac output. And then, of course, we increase preload. You started with that. It's a good discussion. We increase preload, and aldosterone is the primary mediator, but it turns out that vasopressin and endothelin will also do that. All of these are going to cause, at the level of the kidney, sodium and water retention. That's going to increase preload in a heart that already has increased afterload. So while initially these are all good things, we've tipped the bucket. And now Chesty is presenting potentially with decompensated congestive heart failure. At least he's there, very close to it. And the problem with this, of course, also, not of course, but on top of this, is historically, we've not really been able to do anything to slow the progression, but his disease is going to progress because all of these things, all of these signals, epinephrine, angiotensin II, aldosterone, vasopressin, endothelin, are going to contribute to damage in the heart. And it's going to cause the heart to tear. It's going to cause the heart to generate oxygen radicals, to become inflamed, to fibrose. And once we get to that point, contractility is not going to be effective. So our goal with congestive heart failure is to try and slow down the negative impact, since we can't repair that valve, or we can't repair dilated cardiomyopathy in those dogs that have that. What we want to try and do is control the compensatory mechanisms before they put our patient over the edge. So what can we do? What do we have at our disposal to stop some of this from happening? Diuretics. What are diuretics going to do? They're going to decrease that preload. They're going to cause or prevent the retention of sodium. Now we're going to have to be careful, because what happens if we use too much of the diuretic? What happens if we get overzealous? We're going to dehydrate our patients. So we're going to want to do this carefully, but we want to decrease that preload enough so that we're not causing that pulmonary, that increased hydrostatic pressure that's going to cause our lungs to get in trouble. What else can we do? Say it again. We can use ACE inhibitors. What are ACE inhibitors going to do? Yeah, so let's back up, and you're right about this. What I want to know is physiologically, what can we do to offset the effects? So ACE inhibitors, yes. What is it that they do? When we look, we've got increased preload, increased afterload, tachycardia, and increased contractility. The first three things are bad for a patient now. The increased preload we've talked about. What can we do? So what were you saying?
Decrease the afterload.
How can we decrease the afterload? What can we do? We want to dilate the arterioles, and it makes perfect sense to me that ACE inhibitors would be part of our armamentarium, because the nice thing about ACE inhibitors is not only will we get rid of this increased afterload up here, but what else are we going to get rid of? Well, so that's the increased afterload. We're going to get rid of that, but when we use ACE inhibitors, what else are we going to get rid of? So when we get rid of angiotensin II, in addition to getting rid of increased afterload, what else are we going to get rid of?
The preload.
We're going to get rid of the preload. So in one fell swoop, if we can get rid of this signal right here, and we can do it by inhibiting this enzyme, then we will get rid of this increased afterload, and we will get rid of this increased preload. Is that making sense? Okay. Now, still haven't done anything about that rapid heart. What can we do about that? Say it again? Yeah, we can use a beta blocker. Since this is a high adrenergic output state, because his heart rate is fast because of epinephrine, why don't we just reach for a beta blocker? Now, it may not work, and so if it doesn't, then we may have to go to other drugs as well, but that's a good place to start. So, if we can target that increased afterload, that will make it easier for the body's compensatory mechanisms to push blood in the right direction. If we can get rid of that increased preload, it's not going to have to work as hard to generate as much tension in that ventricle to move that blood forward. And if his heart rate is so fast, as we begin to get him in shape, if we can decrease that positive chronotropic effect, then that will give the heart time to respond as well. What's the downside of using a beta blocker in a dog that has congestive heart failure? We're going to slow the heart rate down, but what else might we do? Yeah, we're going to decrease contractility, so we're going to have to be very careful about how we do this so that we don't decompensate his heart. Is that making sense? So when we talk about our cardiovascular drugs, and the nice thing about all this is when we do all of this, we'll hopefully slow that myocardial remodeling. If we do it right, then we will hopefully slow the progression of his congestive heart failure. So when we go through all this, the order of drugs that we'll talk about is we'll talk about using diuretics to decrease preload. We'll talk about using arterial dilators to decrease afterload. We'll talk a little bit about venous dilators as well in an emergency situation. We'll talk about antiarrhythmics, starting with beta blockers, yes, but of course we have to treat other arrhythmias as well. So we'll talk about antiarrhythmics next. And then we'll finally finish with positive inotropes. As Chesty's heart fails, as it becomes unable to contract, then we need to support that contracting heart. And we'll use positive inotropes to help them. What would happen if we were to use, by the way, positive inotropes before we were to use afterload reducers? If we increase contractility before we decrease that afterload, we would potentially cause more damage. So what we want to do is time everything. It's okay to use diuretics first to try and decrease that sodium and water retention. We can do it carefully. But then we're going to want to use something to dilate those arterioles so that anything else we do will at least help the blood go in the right direction. What's the best positive inotropic drug we have at our disposal now? Does anybody know? What's the most popular cardioactive drug now? Bendin? Timobendin? And the neat thing about that drug is it is both an arterial dilator, it decreases preload, and it increases contractility. And that's what's so neat about that drug. All right, that's it. Any questions? If not, then you're out a little bit early. We will start with diuretics when I come back next week.